Question 22, which of the following additional findings is most likely to be present? And it's an OMM question. All right, so a 36-year-old man presents with gradually worsening left-sided low back pain that radiates toward the groin. Okay, so I mean, if you had not done this part where we start with the last sentence and then the answer choices, you'd probably be thinking this is a nephrolithiasis. So this is why I do that. That's why I start at the end. He reports the pain began after hiking uphill multiple days in a row. And then you'd be confused thinking, oh, wait a minute, is this MSK? Yes, yeah, it is. It's OMM. On exam, he has a flexed side bent left L1 L2 segment and limited extension of the lumbar spine. Limited extension of the lumbar spine. So that's interesting. Try to picture that. So I always try to picture this OMM as it's happening to give me a better idea of what I'm dealing with. You can also do like puppet hands, just try and picture the L1, L2 segment being flexed, side bent left, rotated left. But for us, this is the segment, right? This is your L1, and then we'll do L2 here. So it's flexed. L1, L2 segment refers to basically this space here. It's this joint, but in reality, we're talking about L1 specifically. Okay, so let's get rid of that. If we were to modify this, it would look something like this. If this is the spinous process, we're looking at it straight on. So we're going to pretend that it's two-dimensional, but we're going to flex, side bent left, rotate left. Okay, so something like this. We've taken our L1, we've flexed it, which you can't see because that would be going into the plane of the page, side bent it left, and then rotate it left as indicated by the spinous process, now pointing to our right. Now this, with that alone, if you started crossing things off, you would swiftly be wrong, is my guess. This is kind of pathognomonic, maybe a little bit more of a memorization thing, but also you can kind of make sense of it intuitively based off of what you know of OMM. We're flexed after a lot of hiking uphill. So just imagine like picking your legs up over and over again for multiple days in a row. What muscles are being used to flex the hip? It's the hip flexors. So like the psoas. And then where's the psoas in relation to our lumbar spine? It's attached to the transverse processes, originating, inserting, tomato. So if we were to draw in like some transverse processes here like this, then maybe if we draw in the psoas muscle fibers, it kind of looks something like this. All right, so you could have a hypertonic psoas that is pulling this segment into this dysfunction. And that's exactly what this is going for. I've seen several questions on psoas syndrome, and it's just a gimme every time you see it. So I really wanted to make a question on it. But none of the answer choices are just directly saying psoas syndrome. That'd be a little too easy. So let's come over to my expert drawing. This is absolutely terrible, and I know it, but just bear with me. So here I've kind of drawn out the whole spine. I've skipped a few segments. This should be L5, so I can just pencil this in. L5, L4, and then at the very top is our L1. I skipped a few vertebrae. Classically, the way they give this to you is with L3 through 5 being a type 1 curve. So that's going to be, and it's going to be side bent towards the hypertonic psoas because the psoas is inserting on all these transverse processes and then pulling them into this side bending pattern towards the dysfunction. So L3 through 5, classically type 1 curve, side bent left, rotated right in this case, with either L1 and or L2 being a type 2 curve. And I said and or, so it's possible to see both as type 2. I usually just see one or the other though. Okay, I drew these in wrong. They're supposed to be side bent left, rotated right with the spinous process pointing to the left. And that's what that correction was. Imagine these green, the green arrows are the forces that's happening here. This is your hypertonic psoas pulling you in the side bend left, and then the green forces also. I want you to actually just try this really quickly. Go ahead and stand up and just start bending just your spine to either left or right, doesn't matter. And then at a certain point, you'll notice that you're just going to fall over if you keep going. So in order to prevent yourself from falling over, you have to shift your pelvis the opposite direction. So if you're bending to the left, you'll notice that you're shifting your pelvis to the right to stay standing. And that's exactly what happens in this strain pattern. You get forces shifting you to the right. In other words, these big ovals here are supposed to be your pelvis, the innominates. So your innominates are getting shifted to the right to kind of balance you, and that ends up resulting along with possible sacral dysfunction as well, sacral torsions or rotation that happens. You tend to get contralateral piriformis hypertonicity as well. So kind of complex, but just think the spine side bends towards the hypertonic psoas because it quite literally pulls it in that direction, and it pushes the pelvis towards the contralateral piriformis, which kind of stretches it. Maybe you can think of it like that way, and that causes the contralateral piriformis to hold on for dear life and become hypertonic as well. And so here's just a zoomed out view so you can see all our notes. Again, L1 and or L2, type 2 curve. L3 to 5 is a type 1 curve, both side bend towards the hypertonic psoas. And then again, your contralateral piriformis hypertonicity. This is what I tend to see tested the most in this concept. But I've also seen questions asking about your L1 or L2. So if we come back here, we can roll everything else out. I mean, there's no anterior nominate happening. Technically, C, I mean, you could argue that there is going to be a neutral somatic dysfunction here, but it's really going to be L3 through 5. It's kind of the whole lumbar spine. And here, L1, L2 segment, if that's just referring to L1, then okay. But if it's also referring to L2, then, you know, we said that L2 can be type 2. Like we said for part C, L2, L3 somatic dysfunction, neutral side bending. L1, L2 kind of refers to your L1. So L2 to L3 refer to L2. And we know that L1 or L2 can be a type 2. So that's incorrect. L3 through 5, though, can be your neutral curvature. Bilateral sacral extension is not happening. There might be a rotation. Again, I don't see that tested very heavily, but it's not going to be a bilateral extension. And then restricted left hip external rotation. The problem was with the contralateral piriformis causing external rotation. So this is kind of wrong for two reasons. It's not like restricted external rotation. It would be restricted internal rotation on the contralateral side if we're talking about the piriformis. If we're talking about the psoas inserts on the lesser trochanter of the femur, and that causes external rotation as well. So the psoas essentially, in terms of rotation of the hip, acts similarly to the piriformis. So this is also wrong. A hypertonic psoas would cause external rotation of the ipsilateral side, not restricted external rotation. If you're wondering how the psoas rotates the femur externally, I drew it out here. Sort of imagine that this is the head of the femur out of the plane of the page, and then this is the femoral neck coming down. This is just a cross section of our femur, so we're like looking top down on it. This is your greater trochanter and your lesser trochanter. These are posterior structures, so they're not anterior. The spine in the psoas specifically is slightly more anterior. So when it comes down and inserts on the lesser trochanter, it's actually got an anterior vector to its contraction. So it's going to take our entire femur here. So if I overlay these two images here, I lost some of it, but that's okay. You'll see that we are being pulled into farther external rotation with that anterior vector. It's just a little external rotation, but it does matter. And that's just to help you hopefully understand where that external rotation is coming from, and hopefully make you think, like, whenever you're trying to think about a muscle, think about its origin and insertion. It's actually really important to know those, so you can think about the muscle shortening and bringing those two bones closer together. And in this case, if the leg doesn't move, then you'll do a sit-up. If the leg does move and the trunk doesn't move, then you'll pick your leg up and externally rotate it. All in all, the correct answer is A, a right piriformis hyperticity. Please remember that it's contralateral to the affected psoas. So the correct answer is A.